Kathy Van Leeuwen. With Dr. Greg Martin, who's our division chief, we head up a Center for Fetal and Neonatal Care, which I don't know if you guys know about. This is the program that helps all the families when they get a scary prenatal diagnosis. So we create teams for them. That program launched in 2013 under an amazing RN coordinator, Jessica Felt. So I ran into the hallway and said, Jessica, we need to build a prenatal program. She said, I'm in. So, you know, we see last year, 2,200 families. Last year we did close to 300 fetal MRIs. So I just want everybody to know how many babies are in the cooker when we meet them. And in doing so, we really got a sense of what was going on in all of the NICUs in town, especially since you can't have a baby here at Phoenix Children's, as you guys are aware. What happened over the last decade is that there was an emergence of even smaller babies. So even though we created a path for some of these surgical babies to come over to Phoenix Children's to get kind of high-end surgical care, there are still a little cohort of babies that are just so small that they really can't be moved. And those babies got smaller and smaller, and hence the creation of this small baby program. I was fascinated by it as it started to happen over the last decade. And so I invited our amazing speakers today to tell us more about it. So let me get to introducing them. So Dr. Amy Brown is one of our neonatologists, and she heads up the small baby program in basically all of our NICUs, coordinating care for all of these babies. She trained at Sinai Hospital in Baltimore and then did her fellowship at Nationwide. She is a strong believer in relationships with family and family-centered care, which is something that's extremely necessary for these babies. And she's quoted as saying, I love helping these little survivors embark on their life. And I'm sure she's going to tell us how that life is for some of these 22-weekers. So that's something we all want to know. Joining her is one of my partners, Dr. Craig Egan. I call him John Craig Egan because I like to use his full name. That's something that brings me a lot of joy. Craig was born in Redlands, California, and he graduated from Notre Dame. I went to USC, so we like our little rivalry there. Craig did his general surgery residency training at David Grant U.S. Air Force Medical Center and Travis Air Force Base, and then became a general surgeon for a while before going into pediatric surgery, where he did a critical care fellowship at Children's Hospital of Wisconsin and did his training there. We were lucky enough to recruit Craig to come to Phoenix, where he is in charge of our critical care fellowship. And as you guys know, Craig is one of our go-to surgeons at this hospital. So I would like to have everybody give a warm welcome to Amy Brown and Craig Egan.
Good morning, and thank you for having me here. So to start, I have nothing to disclose. The objectives for today's talk. So to understand the need for a more specialized approach to very low birth weight, or VLBW infants, and extremely low birth weight, or ELBW infants. So VLBW infants are infants born less than 1,500 grams at birth, and ELBW infants are infants born less than 1,000 grams at birth. Also, to identify key areas of neonatal care that benefit from a specialized approach in this patient population, and discuss improvements in unit-specific care since the implementation of a small baby program. So to define our population, for our division's purposes, a small baby is currently defined as any infant born less than 28 weeks gestation or less than 1,000 grams at birth. We do have a further subset of 22 to 24 week or periviable infants that have an even more specialized approach to their care. Our key areas of focus, but aren't limited to these, are the golden hour, so the initial 60 minutes after delivery, respiratory care, cardiovascular care, infectious disease, nutritional optimization, and neurodevelopmental care. So although I'm currently the small baby program lead, my role was recently acquired, so I'd be remiss not to give credit to the previous small baby program director, Dr. Mooney Rahman, as well as Megan Shea, who's thankfully still with us, who implemented our small baby program back in January 2022. A tremendous amount of work was done by Dr. Mooney Rahman and Megan Shea to put this practice into place. And this was started at St. Joe's Hospital, where we designated certain units as our borough units to house these small babies. The program is created in response to need for improved care in infants born extremely premature. So for those who may not be familiar with VAUGHN, or the Vermont Oxford Network, this network makes up the world's largest voluntary database for neonatal care and has more than 1,200 members. Reports look at data across all centers, as well as center-specific trends. The Vaughan data helps us to benchmark our own efforts from year to year and also compare that to centers throughout the US and even the world. To help illustrate the need for improved small baby care, the mortality data demonstrates the highest rates in the lowest birth weight infants, which also corresponds to our earlier gestational ages. So looking at the bottom data set, you can see the mortality rate for infants born less than 1,000 grams is about 33%. That's compared to much lower mortality rates in all other birth weight and thus gestational age groups. So all other birth weights and gestational age groups, the mortality combined rate of all of those is about 31%. So still less than the lowest two gestational age and birth weight groups. To further illustrate the need for programs and/or units dedicated to small baby care, I've included this article published in 2022 from Seminars in Perinatology. This article highlights the small baby program at Nationwide Children's Hospital. This program was initiated there in 2004. The paper goes over data for the NCH cohort since introduction of their program. At NCH, there's been a decrease in mortality rate for their small baby population from 30% to less than 10%. Additional outcomes include a shorter hospitalization overall, increase in survival without either severe intraventricular hemorrhage, IVH, or severe bronchopulmonary dysplasia, BPD, two of the most serious comorbidities we deal with in our NICU survivors. Throughout the development, they've experienced stable neurodevelopmental outcomes. And more recently, since 2017, NCH has seen a decrease in their overall rates of BPD. Improvements in small baby outcomes at this tertiary care center demonstrate potential impact of a dedicated small baby unit. An improvement in outcomes for an especially vulnerable population is at the center of our own small baby approach in all of our Phoenix Children's campuses. From a historical perspective, not only has the infant mortality rate dramatically decreased over the last several decades, but the definition of the age of viability has also evolved. So the first red arrow to the left of the figure shows an overall infant mortality rate of about 30 per 1,000 live births in 1960. The gestational age-specific mortality rate in the US in that same year, for infants born 32 to 35 weeks, was about 10 to 12%. Again, in 1960, the infant rate for infants born at 28 to 32 weeks jumps to 40%, and that for infants less than 28 weeks was well over 80% at the time. For this latter group, however, it was extremely unlikely that any attempt was made to resuscitate an infant born less than 27 weeks. In the 1971 edition of Schaefer and Avery's textbook, Diseases of the Newborn, which is one of our core neonatology textbooks, thus at that time estimated the limit of viability to be at 28 weeks and or 1,000 grams, so right at where we define our current small baby population. By 1990, 2 decades later, after the publication, considerable progress had been made, with the mortality at 28 weeks dropping to about 10%, but still progressively increasing to over 90% at infants born at 22 weeks. In our small baby program, the definition of viability does include infants born at 22 weeks, but this definition continues to be a gray area even amongst different centers in the US. Again, advances in neonatal care have incrementally lowered the limit of viability over the past several decades. Peri-viability is the earliest stage of fetal maturity, usually between 22 and 24 weeks of gestation, when there's a reasonable likelihood, although not a high likelihood, that a neonate would survive. The World Association of Perinatal Medicine defined a fetus to be viable when it's sufficiently mature to survive the neonatal period with available medical support. Management of peri-viable infants, however, like the availability of medical technology, varies from hospital to hospital. The variation is evident even in 2 of the references I used for this presentation. The table on this slide, for example, was taken from a paper published in 2023 titled Ethical Dilemmas in Neonatal Care. And looking at the recommendations, the top bar you see for infants less than 23 weeks, aggressive obstetrical care or C-section for fetal indications is highly discouraged. Life-sustaining interventions are not recommended, and palliative care is encouraged and advocated for. For this particular paper at their center, a gestational age of 23 and 0 or 20 to 23 weeks and 6 days, C-sections are not routinely performed, but if the family is canceled and you obtain their consent, it could be acceptable. And then immediate resuscitation of the newborn, although not mandatory, would be reasonable to undertake. Once you reach 24 weeks, so 24 weeks and 0 days, then it would be recommended to undertake obstetrical intervention, a C-section for fetal indications, and immediate resuscitate the infant as well as admit them to the NICU. This next paper was published earlier in 2015 in the New England Journal of Medicine, demonstrates between hospital variation in treatment and outcome of extremely preterm infants. Among infants born at 22 to 24 weeks gestation, hospital rates of active treatment varied significantly. Active treatment was defined as any potentially life-saving intervention administered after birth, which in this study included intubation, surfactant administration, positive pressure ventilation, mechanical ventilation, chest compressions, and/or epinephrine administration. Looking at the figure, you can see the widest variation in treatment occurs among the 22 and 23-week gestational age groups. So 22 weeks of gestations, interventions range from less than 5% to close to 50% and progressively increase as you move on in weeks of gestation. But even within these gestational age groups, there's the overall trend in treatment tends to increase with more days in the gestational age week. For example, there's a higher percentage of infants receiving active intervention at 23 weeks and 5 or 6 days, or 23 versus 23 weeks and 1 or 2 days. So the table included on the slide pulls the survival rates among the different gestational age groups. So on the right-hand side of the table, those are infants receiving active treatment. And then the left-hand side shows the survival rate for overall all of the infants in that gestational age group. At 22 weeks gestation, depending on whether or not there's active treatment, survival ranges from 5 to 23%. At 23 weeks, it jumps to 23 to 33%, with more than half of infants surviving once you reach 24 weeks age gestation. Not surprisingly, as you move up in gestational age, not only does survival increase, but survival without severe or moderate or severe impairment also increases. So moving now to our own division's efforts. Our small baby program was founded with a collaborative approach with centers such as University of Iowa, which is if not the leading center in the U.S. for care of 22 and 23-week infants, Loma Linda, and UCSF. So this photo is actually a group of our neonatologists, nurse practitioners, and nursing staff who undertook a visit to University of Iowa to speak with the unit there, and Dr. Klein, who's pictured on the right. So our work, if we're fortunate enough to meet the family beforehand, starts prior to birth with our periviable counseling. Overall, the goal is to have delivery at St. Joe's. Again, although all of our PCH units follow the same small baby guidelines, the NICU at St. Joe's and the delivery site is the best equipped to care for our smallest patient population. So maternal transport prior to delivery is certainly preferred over transfer of a small baby in the first hours or even the first few days of life, where transferring a very vulnerable infant can not only increase their complications such as IVH, but increase their risk of mortality. So if counseling results in a family indicating that they even might request delivery or resuscitation at 22 weeks and 0 days, we rely on our OB colleagues to administer betamethasone for antenatal steroids. So we will initiate those as early as 21 days or 21 weeks and 5 days so that the full benefit of the steroids can be realized by 48 hours later at 22 weeks and 0 days. In our NICU consults with the family, we use a shared decision-making model to decide whether and to what extent resuscitation might be offered. So we'll go over anticipated course of a NICU stay, how long it might be, and then if the family desires, we can go through statistics that we have available to us for an infant born at a similar birth weight and gestation. So resuscitation from 22 weeks and 0 days to 23 weeks and 6 days consists primarily of airway and respiratory support, but what we offer will evolve based on a discussion with family if we move on further in the pregnancy and how the clinical scenario plays out. Once the pregnancy reaches 24 weeks and 0 days, full resuscitation is anticipated unless there's a serious comorbidity that would impact the infant's chances of survival. So to go over what we do beforehand, the first hour of life, our golden hour, is the vital period of transition from intrauterine to extrauterine life, and an extremely considerable risk of respiratory distress, hypoglycemia, hypothermia, and hemodynamic compromise to the infant. So if at all possible, our team holds a pre-delivery huddle in which we review our known maternal and fetal data, as well as assign roles for the delivery. In terms of our golden hour checklist, we use this for every small baby admission. We input our pre-admission orders so that care gets started as soon as possible. In the first 0 to 10 minutes of life, we perform delayed cord clamping, so the infant stays attached to placenta for up to 60 seconds. The baby at this time is placed in either warm sterile blankets or sterile plastic to help decrease evaporative heat loss. Our NRP is started, and then once the infant is stable enough to think about moving, we call X-ray to meet us in the NICU. From 10 to 20 minutes of life, we are transporting the infant to the NICU with the team, setting up our respiratory support, so usually hooking them up to a ventilator, prepping for our umbilical lines, and administering surfactant once X-ray confirms the tube placement. For the next 30 minutes, we undertake line placement, confirm that placement with X-ray, begin our line infusions, and start antibiotics if they're indicated for the infant. By 60 minutes of life, our goal is to have the isolate closed so that we can start checking the isolate humidity to be in line with our small baby guidelines. So some more specific small baby guidelines to go over include respiratory care, our developmental concerns, so striving for a low stim environment, skin care, nutrition, and cardiovascular support. The lungs, like every other part of the majority of patients we care for, are immature. Traditionally, most preterm infants in the NICU are born in the saccular stages of lung development. Peri-viable infants, however, at 22 to 24 weeks, are likely at the canalicular stage of lung development and even more prone to the adverse effects of mechanical ventilation, such as barotrauma and volutrauma that can lead to complications such as pulmonary interstitial emphysema and pneumothorax. High-frequency ventilation, more specifically high-frequency jet ventilation, is our primary mode of ventilation for any intubated infant born less than 26 weeks gestation. The jet for us is used as first intention for a lung protective strategy, so we can optimize our mean airway pressure with delivering as little as possible pressure rather than being used as a rescue therapy for an infant that was initially placed on conventional therapy and starts to fail that therapy. We have gestational age-specific oxygen saturation targets. So for example, our target goal saturations for infants less than 24 weeks are 84 to 93%, 90 to 94% for 24 to 32 weeks, and 92 to 98% for infants greater than 32 weeks. This graded approach helps to decrease the risk of retinopathy prematurity due to excessive oxygen exposure. Our skincare bundle takes into account the difference in term versus preterm skin development. So the outermost layer, or the stratum corneum, is structurally immature and extremely low birth weight infants. For example, a term infant has about 15 layers of SC. A 28-week infant only has about 2 to 3 layers, and a peri-viable infant may be completely deficient of SC. This skin immaturity contributes to insensible water loss, increased irritant exposure, decreased thermoregulation, and electrolyte imbalances. So our units use guidelines for approaches to isolate humidity, which protective creams to use, what type of dressings to use, when to initiate baths, how often to bathe, and what to bathe the infant with. Moving on to fluids and nutrition. The total body water composition changes as a preterm infant advances in gestational age. An infant, for example, born less than 23 weeks gestation has a total body water content close to 90%. Overall fluid goals for each of our infants are tailored to their gestational age and birth weight and titrated for electrolyte imbalances and insensible water loss in the first few days of life. Moving on to enteral feeds, which are extremely important for gut development, but also can lead to risk of developing complications later on. So we use colostrum, or the first few drops of breast milk, and we begin that within the first 2 to 4 hours of life and use it for oral care. So we'll use a Q-tip to swab the colostrum around the infant's mouth. And then human milk is the standard of care for any of our small babies, using either our donor breast milk banks or express breast milk from mom. The feeding volume, advancement, and fortification of calories is all managed based on gestational age and birth weight of the infant. For our 22 to 23 and 6-7 week infants, the smaller volume feeds are initiated, and they have a more gradual advancement of these feeds compared to their slightly bigger and older small baby counterparts. In terms of cardiovascular support, the immature circulation places extremely preterm infants at risk of hemodynamic compromise. This is due to a number of factors, which include myocardial immaturity, persistence of fetal shunts, so patent ductus arteriosus or even a PFO, adverse effects of ventilation strategies, and side effects of pharmaceutical interventions. Our units use hemodynamic guidelines for blood pressure parameters for each gestational age. We advocate for the early use of hydrocortisone for blood pressure support. So these premature infants are also expected to be somewhat adrenally suppressed. We have a pretty regular use of an echo in the first week of life to evaluate for persistent pulmonary hypertension. For our late preterm and term infants, we would start nitric at 20 parts per million, but for these small baby infants, we use a lower dose of nitric and start that at about 5 parts per million. Our units also use a PDA guideline, which has a scoring tool to help delineate which infants would benefit from therapy. And we use Tylenol as our first line therapy for medical intervention to hopefully avoid the use of NSAIDs, ibuprofen, and certainly indomethacin, which, as you may know, we try to avoid in combined use with hydrocortisone because it increases the risk of SIP. For developmental, our infants at extreme prematurity are more vulnerable to intraventricular hemorrhage, which would play into their prognosis for neurodevelopmental concerns later on in life. Our nurses are extremely good at using our neuroprotective bundle, in which we focus on positioning, so maintaining midline position for the first 7 days of life, a slightly elevated head of bed, using 2-person hands-on care or containment touches anytime we're in the isolette for cares, utilizing early PT and OT services, and strict adherence to our glucose, temperature, ventilation, and blood pressure parameters to help decrease the overall risk of IVH. As much as possible, we strive for a low stim environment, using eye protection, minimizing the noise at bedside, clustering care with nurses and medical team. So when at all possible, the medical team will do their daily exam when the nurse is already in the isolette for cares. These small babies will have every 6-hour cares, which is in contrast to our usual schedule of every 3-hour cares for babies, utilizing containment touch, and then our designated quiet time in our burrows. So there are 3 specific burrow locations within St. Joe's NICU that we can close the doors and have what we call quiet time for 2 hours twice a day. So again, since the program was started at St. Joe's, I just have the early data for the first 6 months and then the first year at this specific site. So in the first 6 months of the program, a total of 22 infants with a gestational age range of 22 weeks and 4 days to 27 weeks and 5 days were born. Birth weight ranges were 370 grams to 1,070 grams. For the 22 to 24 week infants, a total of 7 patients were admitted with an overall survival rate of 58%, which at the time was better than the national average from Neonatal Research Network data of 37% for similar gestational age infants. For our older infants, the 24 to 26 and 6-7 weeks infants, 15 patients were admitted with a survival rate of 87%, comparable to the national average of 85%. A year later, so by January 2023, the second half of the year is on the right-hand side of the slide. So survival overall stayed relatively stable with a survival of about 72%. So percentages are in the parentheses. Any IVH had an incidence of 27%, but 0 of those infants experienced a grade 3 or 4 IVH. And then going down through the line, you can see our rates of PDA, spontaneous intestinal perforation, NEC, severe ROP, early onset sepsis, late onset sepsis, rate of CLABSI, and BPD diagnosis. In the first 6 months compared to the second 6 months, age at discharge was similar with about 38 weeks in each instance. So now to come to our most recent data. So this is our most recent VON data for our St. Joe site. It was released this past June and tracks the site trends through 2023. Top data set gives the overall case number and mortality rates. On the right-hand side, there's an O to E, or an observed to expected number of cases. So for the caseload at a location, a value less than 0 indicates that the center has less cases than expected or is doing better than expected. A number greater than 0 indicates there are more cases or incidents of the outcome than expected. You can see the data is pretty transparent. So it does show that we have a higher than expected rates of chronic lung disease, which also factors into the death or morbidity rate being higher than expected. However, what's extremely encouraging is that the data shows that we are performing better than expected in every other area, with lower than average rates of mortality, late onset infection, NEC, pneumothorax, severe IVH, cystic periventricular leukomalacia, which can also indicate a higher risk of cerebral palsy later on, and severe retinopathy of prematurity. The bottom data set, again, breaks down the rates into gestational age and birth weight categories, which, as was discussed at the beginning of this talk, the lower gestational age and birth weight infants account for a disproportionately high percentage of mortality and morbidity among the neonatal population, hence our ongoing efforts to continually improve our small baby care. To highlight some of our cases, and these photos and stories were all shared with the parents' permission. So this is Jalen. He was one of our very first 22-weekers. So he was born at 22 weeks and 1 day with a birth weight of 480 grams. And in the frame in the photo, you can see that was one of his first pictures in the NICU. So he had a very tenuous course initially. I know personally myself and a number of my partners, we would speak to family without the first few days, throughout even the first few weeks, not knowing if he was going to survive the day, let alone the night or the next few weeks. But Jalen surpassed all of our expectations, ultimately turned his course around, and he was transferred here to PCH on low-flow nasal cannula, so just 1/8 of a liter for hernia repair prior to discharge home a short time later. So he's currently on room air, does not need a G-tube, and thriving, as his mom describes. Some of these audience members might know Miri a bit better, her Muriel. So she was born at 24 weeks and 0 days with a birth weight of 590 grams. Her course was complicated in that she did develop surgical neck, necessitating some bowel resection at St. Joe's, and then later on was transferred here to PCH for bowel reanastomosis. So as her mom describes her, she is still on her own curve for a growth chart, so smaller than most kids her age, but is a very happy and rambunctious 2-year-old. So far, as far as our future directions, we are continually refining and updating our guidelines. So one of our main focuses in the next couple of weeks to months is undertaking revision of our hypotension guidelines for small babies, looking at our use of postnatal steroids to help prevent BPD. And then ongoing quality improvement efforts include use of breast milk during the unit, in the unit, and at discharge, adhering to non-invasive respiratory support guidelines to help further reduce BPD rates, and looking at unit-specific reduction in pneumothorax. Now I'll switch it over to Dr. Egan.
Wow, that's so amazing. And I know that as the surgical group, we see a certain subset of these patients, but to find out what's going on with all of them is amazing. And congratulations for the ongoing progress in that program. So we'll talk about a couple of conditions, surgical conditions that affect these babies essentially at increased risk for these conditions. One is necrotizing enterocolitis, and the other is spontaneous intestinal perforation of the neonate. NEC, as is kind of well known, is the incidence is higher in preterm and low birth weight infants. The more preterm and the more and the lower birth weight increases proportionally, and then the severity of NEC increases as the gestational age decreases. To say that the pathogenesis is multifactorial is a bit of an understatement. This is, I know, a very busy slide, but it kind of includes a lot of the factors that contribute to the development of this condition here. And so strike one, prematurity. They may go into an area where there may be some nosocomial flora that we just, as much as we try to keep them away from. And there's a lot of precautions that the NICU takes in order to protect these babies from, essentially from us. And so those precautions do as much as we can, but they still may be exposed to some of that flora. They may need antibiotics, which then kind of compromise the natural flora in their gut. The gram-negatives may then take over more so than they're supposed to. Then if the baby's fed formula, which I know that these babies are not, which is great. If they were, as some of them used to be fed formula, then that's a substrate for additional bacterial growth without the protective aspects of breast milk. And then the premature gut may not peristalse, may be prone to bacterial stasis, which then the bacteria can breach the mucosal barrier and essentially start this cascade of sepsis, then decrease perfusion, then increase inflammation, and then further increase permeability, which then eventually can lead to progressive bowel damage and full thickness necrosis. Other things we have to consider when we have babies that have this kind of picture include other potentially surgically treatable causes like Hirschsprung's atresias, volvulus or meconium ileus, potentially infectious causes. SIP, like we talked about, we'll talk about more later. Appendicitis is very rare. Other potentially kind of non-surgical causes may be anal fissures, sepsis, milk protein intolerance, and then FPIES. One or a couple of distinctions between FPIES and NEC are that FPIES can have thrombocytosis, leukocytosis, and eosinophilia, which will be different than a neonate that's presenting with NEC. In general, the presentation involves looking at the exam of the baby has a concerning abdomen, concerning X-ray findings, concerning lab findings, and then that can promote us to move into the treatment, which involves holding feeds, treating with antibiotics, and then TPN in order to sustain the infant during the time that their gut is not able to receive feeds. What do we get concerned about? Obviously, it starts with a baby that may have a distended belly, and a lot of most neonates have a convex belly. It's not normal for a neonate to have a concave belly, so their distension is normal up to a certain point. It becomes more distended over time, and we see kind of the skin become more shiny or discolored, then that's very worrisome. And so this is just an example of an advanced case where the neonate probably has either some bowel compromise, ischemia, or perforation. What do we get worried about? Looking at the labs, leukopenia, thrombocytopenia, hyponatremia, hyperglycemia, and metabolic acidosis can be something that's present in the more advanced cases. As far as staging, in order to determine the treatment for these babies, the stage 1 early mild NEC is still in the kind of suspected and colloquialism of neck watch may be applied to this subset of babies. They may have a little bit of instability, A's and B's, lethargy, and then feeding intolerance, some mild distension. The thing that distinguishes 1A from 1B is whether the blood is either hemocoat positive or grossly positive in their stool. Abdominal x-rays may be normal for these babies. And in that case, then we're continuing to monitor their x-rays. And we may start antibiotics in order to treat initially, not fully sure whether or not this is NEC at this particular point in time. Again, it could be a start of another source of sepsis. And so we're seeing how things go on this initial course of antibiotics to determine whether that has to be continued or not. Stage 2 is what we would term proven NEC. The signs of stage 1 may be present, plus abdominal tenderness, and maybe some cellulitis. And the presence of a mass in the right lower quadrant may be indicative of an inflamed ischemic loop of bowel. 2A are mildly ill, 2B moderately ill with metabolic acidosis, thrombocytopenia. On X-ray, the difference between those two would be whether there's pneumatosis present kind of in isolated spots versus diffuse pneumatosis. Again, we're monitoring X-rays closely, monitoring labs closely, and then the antibiotic duration is extended for these babies that have proven NEC. as it becomes advanced or presents in an advanced stage, then the baby can be critically ill, septic, may exhibit peritonitis. The labs may then exhibit metabolic acidosis, obviously, which is a late stage, or lactic acidosis, and can progress to DIC. We have seen babies that have problems with bleeding not only into the belly, but subcutaneous hemorrhage, which really compromises their intravascular volume, which I think is one aspect that I love of the skin care part of the small baby care. In 3A, the bowel is still intact. 3B, there's a perforation showing as a pneumoperitoneum on the X-ray. So for this stage, then the antibiotic are broadened and the duration of antibiotics is extended. On X-ray, the findings that we're going to get convinced about could be pneumatosis, and here at the tip of the arrow, we see an example of what we call kind of bubbly pneumatosis. At the tip of the arrow here, around this loop of bowel is more the kind of the linear intramural pneumatosis. And those are two kind of varieties of the pneumatosis, but we get very worried about seeing either of them. And whether it's isolated or diffuse can tell us how much concern we have about the effect on other sections of the bowel. Then in more advanced stages, we can also see air up in the liver, which is in the portal venous system. And portal venous air is a worse prognosis than just seeing pneumatosis. If we're wondering, based on the plain X-ray, about the finding, is it true? Is it a bit of stool that we're seeing that looks like this pneumatosis? Then we can sometimes include ultrasound in the assessment. And ultrasound can help us look at the thickness and the perfusion as to whether it's normal thickness with normal perfusion, or the bowel wall is becoming thicker with hyperemia. As time goes on, it can see the thickness maintained with decreased perfusion. And then as the mucosa sloughs from the inside of the lumen, then thins out with decreased perfusion, and it can progress to the point where there's no perfusion seen on ultrasound, and as it continues to thin towards perforation. One thing we have to keep in mind about ultrasound is, for these radiographic findings that we will see on plain X-ray, portal venous gas pneumatosis free air, or the things that they can see on ultrasound with the thinning and the absent peristalsis, or ascites or other fluid collections, it's highly specific, but the sensitivity of ultrasound is lower for these findings. Again, as the NEC progresses, it may get to the point where there's bowel perforation and there's free air on the plain X-ray. And so this is something that we sometimes term the football sign, with this outline of air being in the least dependent portion of the neonate's belly. As the neonate's belly is kind of domed up as they're laying supine, the air rise up to the upper aspect of the belly and create this bubble. And in the kind of middle of this bubble of air can be the falciform ligament, which to us, we can kind of see the image of a football with the laces right here, telling us that we have intraluminal air in the intestine and the stomach, but this air is obviously very concerning because there's a lot of free air. Because of the risk of this with the small babies, NICU, other units, ID, and Dr. Molitor of the surgery team got together, and they came up with a kind of unified protocol for treating these babies, which was fantastic, including keeping in mind the risk factors before birth, including how preterm or what the birth weight is, other potentially high risk or increasing the risk based on prenatal factors, and then also the comorbidities of the baby, including cardiac, hematologic, or being exposed to other substances intrauterine. So that sets the stage for whether it's going to be highly suspicious this baby can develop NEC. The treatment protocol then, as we talked about a little bit ago, includes holding the feedings to rest the gut, start antibiotics in order to treat the potential for an infection, even if we don't yet have proven blood cultures, ET tube cultures. We want to jump on this and then assume that there's bacterial translocation across the wall that needs antibiotic treatment, treat them for sepsis, and then the NICU can call a surgery consultation for advanced stages of NEC. If the baby improves that treatment, then the feeds are then started, like Dr. Brown talked about, with breast milk, whether it's expressed or whether it's donor milk, in order to include the immunologic benefits from the breast milk as the feeds are started very slowly for these babies. Of note, it's not necessary in most cases to get a contrast study to prove that the baby's ready for feeding. What we're looking for on the radiographs is the resolution of those previous signs that we just saw a couple of minutes ago. Now, what's the role for surgery? A few years ago, many years ago, at our national conference, there was a session talking about the role for surgery in NEC, and the title was something like, "Is it as useful as rearranging deck chairs on the Titanic?" Meaning that, does surgery help NEC? So the idea was that the surgery for this condition doesn't actually cure the condition. It doesn't halt the progression of the bowel infection or ischemia. So I like to think of surgery as not rearranging the deck chairs, but rather something more like the surgery can be the lifeboats carrying the baby away from the ischemic gut. So as the Titanic is sinking, NEC is progressing, that's the ischemic gut, and we're helping to separate the baby from the ischemic or the necrotic gut, or treat a perforation if necessary. That's a temporary fix. The real rescuers are on the Carpathia here, who came to rescue the passengers with, that's the NICU team, rescuing them with the ongoing 24/7 care, the antibiotics, the TPN, sustaining them during the time when they cannot yet be fed. So after that, once feedings start, then that's, I guess, the passengers kind of arriving in New York and ready to advance on their feeds. Now, risk, we see factors of these babies that increases the risk or indications they might need surgery. That includes birth factors, their comorbidities, and then other factors that are they are undergoing in the NICU that Dr. Brown mentioned, and that can include lines and then other reasons that they may not be able to be fed. Factors that are not necessarily associated or increasing the risk for surgery, but still for NEC, include receiving antibiotics, their weight specifically, receiving these, having a neck and receiving these risk factors here, or the other maternal variables. The mortality can be as high as 22% for babies treated medically. I don't think that's the case here, fortunately, or 46% for the babies treated surgically. As for the surgical approach, there's a subset of patients that may have perforation that may be able to be treated with an abdominal drain, which is a small incision, then draining out the fluid and air, washing out the abdomen, placing a drain, and it's amazing that then there's a lot of these babies that will then heal the perforation with that treatment. If that doesn't work, then we can progress into the treatment with laparotomy. The outcomes for these babies is not significantly different based on which of those surgical approaches is initiated first. What we don't like to see, but what we have to save the baby from essentially is gut that's going to make them sicker. So we can have patchy ischemia and necrosis and potentially see areas that are obviously compromised and need to be resected, or other areas like this loop back here, which may not be fully ischemic or necrotic. And then in terms of trying to maximize their gut length later on, we're trying to give the baby more time to look again surgically in another 24 to 48 hours to see what the gut is looking like at that point. Has it improved, or has certain sections necrosed and need to be resected? The worst case scenario can be what we call nectotalus, or gut that is just completely lost its perfusion and is very, very close to perforating and liquefactive necrosis. In this case, then there may not be enough bowel that's going to sustain the nutrition for the baby long term. Now, one goal of surgery is to take out all the compromised gut. Like I said, it may take a day or two to determine how much of that gut needs to be resected, but it's really the goal is to get rid of it all so it can the inflammatory mediators in that gut can be separated from the baby, so the baby has healthy gut to work with going forward. So the survival is improved in the blue section here with babies that had all of their compromised gut resected. After that, do we resect? After resection, do we anastomose, or do we give the baby a stoma? Some of the babies, it's very obvious they're improving. Some of the babies, it's very obvious that they're not. They're still spiraling. So in general, with babies that have been compared from having one to the other, those babies not being necessarily the sickest babies, an anastomosis has helped to decrease the number of operations, length of stay, and get the baby to feeding in about the same amount of time with no additional complications. The end goal is having the baby be enterally independent, meaning not needing TPN. And so we're looking at what the likelihood of that is to happen. If the baby has a shorter length of gut, then that's less likely to happen. If they've got a longer length of gut or an ileocecal valve, then that's got a better chance of happening. Obviously, if they don't have sufficient gut, then that's not going to allow them to get off of TPN. Now, moving into the other entity called spontaneous intestinal perforation, this is also the babies also are increased risk if they are lower birth weight and more premature, and their mortality also is elevated with extremely low birth weight infants, which is about twice of what those babies would face without SIP. Risk factors include maternal risk factors, infant risk factors, the NICU interventions that are necessary. Interestingly, caffeine not necessarily a risk factor, and in some studies is potentially protective to these babies. SIP then portends a higher risk of death, sepsis, or BPD. And then the survivors later on can have higher risk for BPD, ROP, and neuro complications. So infants with lower gestational age have higher risk to have something done surgically, and their overall case fatality rate for the patients that need surgical interventions in this entity is also not significantly different based on the initial intervention. And the infants that needed surgery benefited from having what they called for full complete surgery rather than just a abdominal aspiration. However, The surgery can include placing a drain or doing a laparotomy up front. And so again, placing a drain here initially has been seen to have equivalent outcomes to the babies that start with having a laparotomy. So similar to NEC, SIP is independently associated with increased risk with death, length of stay, BPD. Caffeine may be protective. It is a topic in a neonatal condition that does require additional study and additional investigation. Happy to take any questions for either of us. Please remember to do the evaluation with the QR code.
Developing these small baby units, they're very cool. Those of us who get to go over there and see the care that the nurses are, especially the nurses that are giving over there, is amazing. But how do you communicate with other hospitals about that? Do you guys get a call about these moms when they're in labor and they're 21 weeks?
Yeah, so most of our babies, our moms at St. Joe's will come from basically our sister hospital, so Mercyville, and the OB side will arrange for maternal transport. So if they have a mom presenting with premature rupture of the membranes or threatening labor, they will do everything possible to get the mom sent to St. Joe's prior to delivery.
So is there some education going on for those centers about these babies and why to get them over to St. Joe's?
Yeah, fortunately, with us, our NICU team being in all the NICUs, if we get a consult at an outside hospital for them to transport to St. Joe's. So anytime a mom comes in, they will comes these outside hospitals, especially I think the fetal care network has been super helpful in just kind of spreading the word that if you're going to deliver a small baby, it needs to be at St. Joe's.
Here's one in the Q&A. Okay. Abbott Labs, who makes most of the premature formulas in the US, is being sued for quote unquote causing neck, and human milk is not able to completely meet the needs for NICU. Any thoughts on this? I saw an interview with the CEO of Abbott Labs where he said that Abbott felt it was a need they wanted to continue to meet, but it's reportedly not a very profitable area for Abbott. Any worries that premature formulas may not be available in the future and the need for more human milk donors and milk banks?
Yeah, it is a concern, absolutely. So although we utilize human milk as our base, so at a certain volume, these infants be fortified. So we need to add additional calories, additional fat, calcium, phosphorus, and the needs and just plain breast milk aren't going to meet the needs of the premature infant. At our units, we are lucky enough to have Prolacta, which is a human milk-based fortifier, but that's only eligible for certain infants. And again, that's can be controversial in itself, but after a certain age, we have to transition off Prolacta because of the cost. So even though we start with unfortified human milk, at some point these infants are going to be exposed to formula. So we use human milk fortifier, which is a bovine-based fortifier, but does come from formula companies. And that is pretty essential to their nutrition once they're stable enough and on enough volume of feeds to tolerate the fortification. So that is a concern, and I don't know how to solve that, unfortunately, but certainly a concern.
Another question from a gastroenterologist. Excellent grand rounds. Is there a thought of including adult medicine in this collaboration to prepare the grounds for education on needs and transition care one day?
Yeah, actually, our here at PCH, we are have started a gut rehab program, or a short bowel rehab program that works with surgery as well as gastroenterologists. I think that's in the works here at our main campus. But I think the more we can get adults involved would be great, because we, as you said, we are going to transition care to them once these babies are ready to go home.
I want to give a quick shout out to our palliative care team too, which does a lot of these prenatal consults that helps with the shared decision making parents. But I have a quick question for Craig. Like your take on the more aggressive surgical neck with an ostomy versus just, resection? Let's conversely on SIPs and neck. Do we do an ostomy? Do we get more aggressive about it? Do we just try the drain and try to get them through? What's your personal thought on it?
Try to generally, if there's evidence of preparation, I'll start with the drain. If we see the drainage then taper off and the belly starts looking better and the baby starts improving, then we just start backing out the drain. If it's not, if the baby's not improving or the intral succus draining out of the wound is not improving, then that's a baby to take for laparotomy. If there's essentially no evidence of perforation, but there's evidence of bowel ischemia and worsening acidosis, then I'll usually want to take those babies to laparotomy. And then as far as what we do after that, stoma versus primary anastomosis, hopefully over the period of days that we're watching the gut and deciding how much of it needs to be resected or not, the baby will declare as to being stable or not stable. If they're more stable, then we feel better about doing an anastomosis. If they're not, then we may pull out a stoma. But that's something that is an area that's still a conversation going on. And I think there's a lot of times where one of us in the OR will call in another partner to have a look and get our opinions and our brains together on it, see what's best for that particular baby.
Dr. Brown, what have an idea of what the experience, conversations, growing pains have been on the OB side with not only more deliveries but higher risk deliveries?
So some of the initial growing pains, which I think we've hopefully addressed for the most part, is getting them to administer the antenatal steroids as early as 21 weeks and 5 days. So there have been times early on in the small baby program where myself, our colleagues have been called to do a consult, and we said, well, if you even want us at delivery, we need to have these steroids on board because they increase survival by about 10% right away, decrease risk of neck, IVH, and BP long term. So those are certainly some of the more initial growing pains. But it seems to me that our OB colleagues are handling the influx of more high risk deliveries well at St. Joe's, at least from my experience.
What are you thinking for primary interventions for reducing chronic lung disease forward?
Yeah, that's a great question. Oh yeah, he asked what are we thinking about primary interventions for decreasing risk of BPD? So traditionally, quickest way to decrease risk of BPD is to get these babies extubated. But when you're looking at a 22 or 23 weeker, when you're 3 or 4 weeks of age, they're 26 to 27 weeks, which is not an unreasonable amount of time to have these babies intubated. There are centers like Iowa who tolerate babies being intubated for longer time. So I think having a baby be as stable as possible on the lowest settings that we can provide. And then when we are in that window where it seems like the baby will tolerate extubating, trying to extubate as quickly as possible. And for our older babies, one of our physician assistant who used to be a respiratory therapist wants to work on is advocating for more bubble CPAP directly. So coming straight out of the delivery unit, maybe get in and out surfactant placed on directly onto bubble CPAP rather than being intubated. So certainly the earlier we get these babies extubated, the better.
Chain on developing neck, the first thing was, bad flora. Is there any interventions where people are getting good flora and putting that in the babies right away to hopefully improve the microbiome from the get-go?
There are some promising studies with probiotics, but again, that it's something that is also recently in legislation. So our units have backed off from that, but the most promising studies have been with probiotics.
And thanks so much for your expertise.